So this is a 51-year-old man. He's new to me. He was diagnosed approximately 2 years ago with Hep C. He has no history of IV or intranasal drug use. He has no tattoos, never been in prison, no sharing needles or razors or toothbrushes. He does have a history of unprotected sex, so I'm assuming that is the transmission. I'm not sure otherwise. He has a history of asthma, vitamin D deficiency, and allergic rhinitis. He's currently just on albuterol and vitamin D. He's immune to Hep A. We started his Hep B. He's immune to Hep B. We started his Hep A vaccines. Oh, otherwise, his labs are pretty standard. His platelets are 286. His ALT was 70. His AST was 97. His APRI score was 0.565. Iron was good. His vitamin D was low. HIV negative. His genotype is 1A. His viral load was 68,500. So I was considering Maverick. I didn't do any other imaging or anything like that.
Thank you so much. All right, does anybody have any questions for Gary before you go into the recommendations? Had that echo pause. I think we're good. All right, the recommendations, please.
Is that me? That's me.
Just know, Dr. Gilfus is amazing at this, but everyone is welcome to chime in too. We like to hear.
Yeah, no, definitely. Anyone else who wants to talk, we'll do it more articulately. See, even I messed up the word articulately. That's terrible. Anyway, Gary, good job. Weird case because he really doesn't know where it's coming from, and either that's a disclosure issue, he doesn't want to tell you, or he really doesn't know. It's interesting. At some point in his life, there was some high risk exposure because he got Hep B as well. His core antibody's positive. So yeah, it definitely speaks to some risky behavior in the past. And even though we don't tend to think of sex and Hep C, it's possible. So my only issue with this guy is the duration of infection is unknown. If we knew that he was exposed less than 10 years ago, I would forego imaging and everything else, and I'd just treat him. However, because we literally don't know if he had, maybe his mom had Hep C and Hep B, and he was a perinatal acquisitions dealing with 50 years of this. I would actually image him. I would say that we need at least an imaging procedure and maybe even a FibroSure at some point. I didn't see a FibroSure on there. Maybe I was wrong.
Oh, sorry, I might have missed that. Give me 1 second.
Sure.
It is. The FibroSure shows F0, F1.
F0, F1. Lucky man. Yeah. So, but that's I would probably grab imaging on him just for fun, as my third triangulation point. And as long as it doesn't show a little scarred cirrhotic liver, you're rocking. You have no suggestion in your APRI or your serum biomarkers that you would need to do long-term HCC screening on him or anything. So he's probably just a treatment and cure. And you're right on genotype 1A. You got all your options. His viral load is low, so you could either do 8 weeks of Harvoni, 8 weeks of Mavorite, or 12 weeks of Epclusa. All are valid options. I'm not sure what his UPMC insurance prefers, but those all seem fine. Remember, if they did require Zepatier, you'd have to do the polymorphism test. But I seldom see insurers request that. The only other thing I wanted to point out, and it was just purely to take advantage of looking at his creatinine. His creatinine's okay, 1.35. But sometimes a question comes up, what if people have bad creatinine? Are there any limitations on any of our medications for renal dysfunction? And the answer is no. We didn't know that when the drugs first came out. And In fact, the initial niche for Zepatier at first was in people with bad kidneys, but now it looks like all of the drugs are safe in people with not good kidneys. So that is a non-factor. So, but good presentation, man. I think you can give him any of those options, and I would probably image him just for fun, and no HCC as long as he's clear.
Okay. Thank you.
Great,
I
thank
should
you
say
so
no,
much.
HCC screening. Sorry, bad, poor English again on my end.
Gary, do you have any other further questions?
No, thank you.
Of course, thank you so much for submitting that case. All right, I don't see Dr. Root on yet. So Alex, are you ready?
Sure.
Excellent. All right, go ahead and share that screen. And go over to yours. Give me 1 second. All right, you should be good to go.
So we have a 36-year-old male who's white and receiving Medicaid insurance. He received a diagnosis of HCV in 2018. He presented to Tug River to start to establish care and receive treatment. No alcohol abuse, 21 pack year history, no current illicit drug use, but he has a history of injectable drug use with heroin, and then also abused fentanyl and high school graduate. He has a past medical history of depression. The current medications that he's on is bupropion, cetirizine, mirtazapine, loratadine, hydroxyzine, and Suboxone. So his transmission risks is he's a former IV drug user and received a non-professional tattoo while he was in prison. And in the past 12 months, he has used injectables. He's Hep A and Hep B vaccinated, and he has a BMI of 24.5. So for his labs, he had a white blood cell of 13.5, an ANC of 8.2, which is slightly elevated, hemoglobin of 15.8, hematocrit 46.3, platelets of 545, which is elevated, creatinine of 0.87, glucose 72, a ProTime of 10.1, which is slightly low, INR of 0.9, albumin of 4.6, an ALT of 120, an AST of 34, alkaline phosphatase of 110, which is elevated, T-Billy 0.8, direct Billy 0.25, total protein 7.7, and a APRI of 0.156, child Turcotte-Pugh classification 5, MELD 6, TSH 1.33, hemoglobin A1C of 5.6, urinalysis was pretty normal. He had an iron of 132, total iron binding capacity of 444, ferritin of 17, vitamin D of 29.9, AFP of 4.7, HIV antibody negative, HCV genotype 3. He has a HCV viral load of 1,280,000. He's F0A2. Also, for complicating his past medical history, he was shown to have a positive quantiferon gold test, and he subsequently received a PPD and chest x-ray, which were negative. He's currently following up with the health department and is not currently on any medication. So our questions were, is the treatment plan glecaprevir pembrolizumab for 8 weeks, 140 milligrams daily, and does he have any drug interactions?
Great job, Alex. Thank you so much. Does anybody have any questions for Alex before we go into the recommendations?
Just one, Alex. John here. Do you know when his risk factors of injection drug use began? So we know that he had them as recently as a year ago. As being a 36-year-old, just trying to get a sense of how much head start the drug use might have on us, either that or his tattoo, whichever came first. His first drug use or his first illicit tattoo.
I'm not quite sure. I know that his vaccinations were in 2017, 2018, and he received them when he went to prison. So that's at least probably around the time that he got the non-professional tattoo, but I'm unsure about his injectable drug use history.
Oh, that's not.
Any further questions? Sorry. All right, recommendations. Does anybody have recommendations before Dr. Gilfus goes?
Great. Silent group today. And Alec, good presentation, man. So you're a third-year med student presenting? That's awesome. Heck yeah. Doing it like an old pro. Love it. And by the way, I don't even struggle with those generic names. So I give you credit for trying. I go straight to the brand names because I can't say them. So yeah, just to stress the point, when you do have somebody who has a an established risk factor, obviously to ensure the sobriety period is met, UPMC's, Medicaid's sobriety requirements are met. You need to make sure they haven't used in the past 3 months, which it sounds like he's not. But the other important data point is, trying to figure out when they first injected so that you have a sense of how long of a head start the hepatitis virus might have had. And this guy's got genotype 3, which in terms of natural history, we normally talk 20 to 30 years until you get advanced liver disease or fibrosis for most genotypes. And that might accelerate a decade or so with genotype 3. So as opposed to genotype 1, 2, 4, 5, 6, all the rest of them, they tend to be the slow 20 to 30 years given no other, major cofactors, whereas, 15 to 25 for the genotype 3. So fortunately, he's a young man. So he's clearly does not have an advanced APRI or I think his fibrosis score is okay, right? I forgot to stare at it. Hang on. Yes, his fibrosis score is an F0, so really good. So he'll be a prime candidate to treat. In terms of the therapeutic, I don't personally see any issues with giving him Epclusa or Mavorite. Epclusa for 12 weeks or Mavorite for 8. Neither of which, because he's not cirrhotic and really no concern therein that he would need any prior resistance testing. So in other words, no resistance testing prior to treatment. So you'd be able to just go in and treat them. None of us like genotype 3 because, well, not only does it go faster towards fibrosis, but it traditionally has a little bit lower response rates, where as we talk 99s for most of the other genotypes, we often talk in the low 90s for the genotype 3. But honestly, with Mavorite and Epclusa, given the right duration and non-cirrhotic, I expect cure still. The only other, and please supplement this guy's vitamin D in case he's not on it. I didn't look if he's on vitamin D. I'm gonna let Rachel Mitchell and her gaggle of PG4s and other students in residence she has with her discuss the interactions. But the last thing I want to mention is extrahepatic manifestation. So this guy's case initially just looks like a bland 36-year-old with genotype 3. But so if you get adventurous, you can sort of see potentially a couple extrahepatic manifestations at play. And the ones I mean in particular is, remember, depression is considered a clinical manifestation potentially of Hep C. So that might improve as you treat them, number one. And number two, remember cardiovascular risk in Hep C. And why am I bringing it up? Because this guy's a 36-year-old and his white count is 13.5. So one of the poor man's risk stratifiers for cardiovascular risk is actually the leukocyte count. If you do a population survey, those with higher white blood cell counts have increased risk of cardiovascular disease. So that's check number one against him. Number two, he's a smoker. Number three, he's got Hep C. So you suddenly are having this guy who has advanced or I should say accelerated cardiovascular risk, even more motivation to treat him above and beyond just liver health. You may actually be decreasing his cardiovascular risk long-term by getting the hepatitis C out of the picture. So, and remember that chronic inflammation from Hep C, one of the ways it kills you is cardiovascular risk factors. So kind of cool, extra little motivation to treat him. Alex, I didn't ask you this, but the only other thing, his CBC to me looks like he has, does he have a spleen? I don't know if that's on his medical history. Has he had a splenectomy or something? With the high white count and high platelet count, it makes you just wonder if he's had an old trauma to his spleen or something. But otherwise, that's the only learning points I can get on him. And no HCC screening. After you treat him and cure him, he's good to go.
Yeah, I'm unsure about if he's had a splenectomy before.
Totally impertinent, just my curiosity. Remember that you tend to see higher platelet counts and higher white counts in splenectomized patients. But again, just some people have high white counts and they are not people who should smoke or have Hep C. They're going to have a stroke or heart attack earlier in life than others. And Rachel et al., I'll defer to you guys on drug interactions.
All right. So as far as drug interactions with these medications that he's on, I don't see any issues with either the Mavorite or the Epclusa. Both of those are fair options for this Medicaid patients, and so they'll cover both of those. The only thing to watch for, if you would for whatever reason go with Epclusa, always screen the patient, make sure they're not using any OTC things that are acid suppressing, because that can decrease the efficacy of the Epclusa. So anything from your run-of-the-mill Tums and Rolaids all the way up to your PPIs like your omeprazoles, want to make sure that they're either not taking those or taking them at appropriate dose, and we administer them correctly with the Epclusa, because it'll decrease those concentrations and risk failure. But I don't see any interactions here with the Mavorite, and that is the shorter course of treatment here.
Thank you.
Excellent. Thank you so much, Rachel. And thank you, Dr. Gilfus and Alex. You did a really great job. Thank you very much for submitting that case. If you have any other questions, please let us know. All right. Dr. Rood, are you okay to present?
Yes, I am. Sorry, I'm in the car.
Oh my gosh. Okay. Well, please be careful. I can
not
read through this if someone else can. One moment.
Okay, so this patient is a 37-year-old lady. She is kind of a longstanding patient of our clinic. She is insured by Medicaid. She came in just for follow-up of her chronic Hep C. So physical exam was normal for her. She was diagnosed in 2017. Her exposure history, she did use injection drugs from 2014 to 2020. She hasn't used since 2020, has been in an MAT methadone program since that time. She says she also worked in a nursing home and had some blood exposure in 2015, but I would say her likely exposure was the injection use. Comorbidities for her, she does smoke, she's a tobacco use history, and she has some hip pain. So for that, she's on Wellbutrin to try to help with her smoking cessation, and then Loxicam daily for her hip pain. She is not immune to hepatitis A. We have started vaccines for her for that, but she is immune to hepatitis B, and her surface antibody was super high at 885. Her BMI is 32. Lab work wise, her CBC looked pretty good. Her platelets were okay. Her kidney function is fine. AST and ALT were a little bit elevated at 69 and 79. Her bilirubin was fine. Her APRI was 0.6. CTP score of 5. Her vitamin D level is low, so we're replacing that. Her HIV was negative. She is genotype 3 with a viral load of 2.7 million, and her serum fibrosis marker was F0. And then her other Hep B serologies were also negative. So one of my questions for her was because of with the genotype 3, how the fibrosis can happen quicker, even though she was an F0 and her APRI was okay. I didn't know if there would be any utility in getting a liver ultrasound in her. Just this one time. And then because of her insurance with Medicaid, I was thinking Mavorite or Epclusa.
Great job. Thank you so much, Dr. Rood. All right, does anybody have questions? All right. the recommendations portion.
Fine. All right. Dr. Root, just so impressed at how advanced you are already. You don't even need me at all. I 100% agree with you what your plan is. I just give Mavorita or Epclusa for 8 weeks. I would not bother with the imaging. Her very, very excellent elucidation of her potential exposure time period. We're talking less than a decade. Even in worst case scenarios, it's exposure was 2014. So, we just plain old don't have enough time, given an absence of other cofactors, for her to have accelerated fibrosis, even with genotype 3. So I don't think you need to bother with the ultrasound imaging, because you've got a normal APRI and a normal serum fibrosis biomarkers. So great job. She'll be a excellent lady to cure. 37-year-old, still of childbearing age. Get that risk of mother to child transmission down to 0 and make her feel better. That's great. So, and again, ditto advice for the last guy. No reason for resistance testing ahead of time, because you don't have substantial scar tissue in there. So no long-term HCC, nothing. So great job. Impressed.
Thank you.
Thank you so much. That was great. Dr. Reed, do you have any other questions?
No, I don't. Thank you so much.
Yeah, I forget. Remember, I did mention that. I forgot about that until I said it while talking, because birth control. It has to be the only other thing you talk with her about a little bit. And abstinence counts, I think, if that's an option, or if you do, Rachel will touch on this if you need to, but as long as Mavri, one of the protease inhibitors, is in the treatment differential, you need to avoid certain birth control medication.
Yeah, that interaction is with the ethinyl estradiol. So your combined hormonals, because pretty much all of them use ethinyl estradiol as the estrogen component. So all the progestin onlys, the long acting, so your depots, your Nexplanon, and then the drug eluting IUDs are all progestin only. So those are all good options. Mostly you're going to be worried about things like your oral combines, and then things like the Nuva ring that's also got the ethinyl estradiol in it too.
Okay, awesome. Thanks.
Yeah, and it's there's not known teratogenicity of these DAAs, of direct acting antivirals. Our big hang up on pregnancy and Hep C is the lack of data, number one, and the recollection that our old treatments, the ribavirin and interferon, were clearly terrible for unborn and actually even unconceived children. So it was a major deal. Yeah, it was crazy. Like, ribavirin is just about the most horrendous drug you can think of to give someone of child birthing or creation age. So either male or woman, you can't use it. So anyway, that's a big hold up for Hep C drugs. But really, you just can't. Unfortunately, we just don't know. So you got to make sure people don't get pregnant.
Thank you so much, Dr. Gilfus and Rachel. And thank you again for another wonderful presentation, Dr. Rude. All right, I think we'll go into the didactic portion. I had made you a co-host, I believe, Dr. Gilfus, unless you want me to go through your slides for you. It's no problem.
No, am I completing the Hep B thing? Is that what I'm gonna do?
Yes, yeah,
Oh,
exactly.
cool. Nice. Yeah. I have to find it real quick, and then I will get it pulled up. My bad.
Oh, no worries. No worries at all.
Okay. I think everybody can see it, hopefully. Actually, I should assay that. Can you guys
Yes.
see it? All right.
Yes, we see it.
Sweet. See it and hear me. So, last time we just talked about Hep B, how there's a few differences between Hep C and Hep B. It's a lot more sexually transmitted. We can't cure it. There's more mother to child transmission. It's a major issue worldwide, and it's way more oncogenic. That's sort of what I covered last time. And I ended on, oh, this, and then just as a reminder, I talked about the fact that if you're exposed as an adult, you tend to 95% of the time you cure it, which is awesome. It's way different natural history than hepatitis C. Whereas hep C, the minority of people will clear it. Hep B, the majority of adults will clear it. And I ended on, if I'm not mistaken, I ended here on the hepatitis B serology, which is what a lousy place to end, because that means I have to start with it. And it's nobody's favorite. And this whole gobbledygook is a holdover. The fact that we have so many antigens and antibodies that we look at is a holdover from the fact that this was a disease that was diagnosed, or I should say first discovered in 1966, and there was no PCR. And I wish hep B would be forgotten about and rediscovered in 2022, because we'd have much easier testing, I guarantee. We'd have like antibody test and then a confirmatory PCR a la hep C. But we don't have that. We have, we do have that, but we still use all of these other antibody and antigen combinations to exquisitely, perhaps over describe where people are in the sequence of their illness. I'm not going to go over this because it makes a really boring lecture, but just know that you can check surface antigen, surface antibody, core antibody, E antigen, E antibody, DNA. So you can check all that stuff. And in fact, if you ever have a case where you're not sure where somebody's sitting, I advise you collect all of those data points and plot them out. There are some times when I will pull up a patient's chart and I can't figure it out just using my brain. So I'll pull up this graph or a similar graph and plot somebody and be like, aha, okay, so this is somebody who looks like they're on their way to clearing, et cetera, et cetera. So no reason for me to go over like 14 contingencies on here. Just know that that's what normally happens is as your antigens drop, your antibodies increase. And the DNA actually, if you do check it, tends to be the earliest marker. And so on and so forth. Unless anybody has any particular questions on the serology. I'm going to get to the question last time. There was a question last time that said, what about isolated core positivity? And I promise I'll touch on that. And remember, hep B becomes chronic, or the carrier state, after 6 months of surface antigen presence. So much like hep C, we define it as chronic hepatitis C after you've demonstrated your body doesn't clear it after 6 months. For hep B, we do the same. We use the same definition conveniently. So if your body doesn't clear it after 6 months, it's called chronic hep B. And the only difference is it's much more likely that your body actually clears hep B than hep C. Okay. And then if you were to look at the serologic pattern, this, squiggly lines, if you looked at the serologic pattern of somebody who develops chronic hepatitis, basically they just have persistence usually at the DNA, surface antigen, and E antigen. So those, as opposed to declining and turning into anti-E, anti-surface antibody, and then in the decay of the DNA, they persist, and so on. Okay. By the way, if I literally could reinvent hep B today, I would have the core antibody be your screening test and the DNA be your confirmation. It'd be that simple, because the core stays positive for life. Don't do that. Everyone's going to be like, why didn't you check X, Y, or Z? But that still, it would work. All right. So getting to that question that one of the spoke members asked last time, what about isolated core positivity? This happens a lot. We see isolated core positivity. And a lot of times the question is, what does it mean? Should you vaccinate? It can mean about 4 different things. It can be a false positive. I can't say that I've ever truly seen that. It's always listed as a possibility, but usually you can come up with an alternative answer. The most common false finding on hepatitis B testing is a false positive surface antigen. And the most common answer for that is someone got the vaccine recently. So remember, if you give someone the vaccine, you're actually giving them surface antigen. And if you then check that in blood work within the next 30 days, you can find it. So not uncommon to find a false positive surface antigen. But false positive core antibody apparently can happen. I've just never seen it. It can also be in the window period. So what is this window period? This window period is this part right here. When the surface antigen is declining, And before the anti-surface antibody increases, there's this time period where you can't find either the surface antigen or the surface antibody. And in that scenario, you'd have isolated core. Now, it's a bit of a misnomer. It's just the only antibody that you see if you draw your traditional antibodies. If you checked your E antibody or antigen, it'd probably be there. If you check DNA, it'd probably be there. So, but just with the classic things people check with surface antibody, surface antigen, and core, that's the window period. Okay, so it could be the window period. It could be a resolved hepatitis B infection with waning anti-surface antigen titers. This is probably the most common answer for what we see. So it's somebody who doesn't register as a positive surface antibody, but it's there. It's just low. It's below the quantitative value. Okay, so in other words, their Hep B was 50 years ago, and they no longer are demonstrating anything but the core antibody, which stays very high. And then the other tricky one to remember is low, what we talk about all the time in Hep C echo, and that is Hep C co-infection. And remember that Hep C co-infection can induce this isolated core positivity by sort of suppressing all the other viral replication activities of Hep B. And that gives rise to our whole serologically silent Hep B when you have Hep C co-infection. So, you know, my advice when you do have this isolated core positivity, check all your other Hep B indices. And gosh, I'm missing a giant suggestion on here. It should also, make sure you check Hep C antibody testing. So you want to make sure you look at your Hep B DNA, your E antibody and antigen. And then the question about vaccination, the only scenario up here that makes any sense to vaccinate somebody is if they're a false positive. So in general, you don't need to. That being said, a lot of docs will suggest go ahead and do it because there's no harm. So if you do have somebody who had prior Hep B exposure, has core antibodies due to that fact, you can feel free to vaccinate them as often as you want. It's not going to hurt them, but you don't have to. So that's why you'll often see disparate advice on these patients. You'd be like, yeah, go ahead and vaccinate them, don't vaccinate them. There's no harm, but you probably don't have to. Any questions on that? Common question comes up. All right. So how about treatment? Now, hepatitis B treatment is a tad frustrating. It's analogous to HIV treatment in that we don't cure people. And you want to drag your feet on Hep B treatment. In general, if you identify someone as having hepatitis B, you want to make sure that you know where they are on the time scale of things and make sure this isn't somebody who's going to self-resolve, because again, 95% of people will. And really, there's nothing you can do to speed up that 95%. You just sort of watch and wait, and only consider treating chronic Hep B in most scenarios. A couple other weird examples where you treat acute, but in general, you just wait. Now, this is a completely cardinally different paradigm than Hep C. So remember, the treatment paradigm for Hep C is treat Hep C. Now, super simple. Hep C, treat Hep C. How about for hepatitis B? You treat a minority of patients. And the factors that we go into to determine whether or not someone needs to be treated are quite complicated. They are definitely above and beyond what we need to cover today to actually know them, but just know that the various things we look at is their E antigen status, whether they're E antigen positive or negative. We look at their actual DNA level. So that's very different than Hep C. Remember, in Hep C, one of the things I always say is I don't care about their PCR level outside of whether or not we're going to give a short course Harvoni. That's literally the only thing we look at for Hep C and the viral load. Otherwise, it doesn't enter into treatment or not treatment decisions. It's either there or it's not. But with hepatitis B, the actual DNA level matters. And that matter at which we consider treatment varies if you're cirrhotic or not cirrhotic. With Hep B, you don't even offer treatment to most people unless their liver enzymes are at least 2 times normal. And you want at least an F2 and an elevated activity score on your FibroSure. So in other words, a lot of different factors we look at in combination to figure out if we want to treat people. And we want to wait, as I mentioned, all this slide says is wait. Wait a little while because people can clear it on their own. And a very important factoid, make sure that your patient doesn't have an HIV co-infection. And the rationale for that is coming up. right here. So the treatments that we tend to use are HIV medications. Remember that we talked about this, the DNA polymerase of Hep B copies itself to an RNA and then back to a DNA. So you can use reverse transcriptase inhibitors to sort of to work. It works for treating Hep B, which is great. The reason you want to make sure a person doesn't have HIV before you treat their Hep B is because the last thing you'd ever want to do to an HIV positive patient is treat them with monotherapy with any of these drugs, or you'd have rapid resistance develop, which can jeopardize their HIV care. Okay, so there are other treatments available, but these are really the top ones. And most of the time, we really use entecavir or tenofovir nowadays, either of the tenofovir derivatives. We prefer tenofovir in women of childbearing age because there's good safety data on it, but entecavir is fine for older people. We don't use much lamivudine because it becomes resistant pretty quickly. I'm gonna go back a slide. So when we do treat hepatitis B, as I mentioned, it's sort of analogous to our HIV therapies. We don't cure, we control. And we want to see things improve as you treat people's Hep B. You want to see their DNA go away. You want to see their liver enzymes improve. And you'd love it. You'd actually love it if their E antigen turns into an anti-E. So if they develop anti-E, that's a good thing. And in fact, that's general concepts of induction and consolidation treatment really refer to, you'll see people talk about the induction phase of Hep B therapy and then the consolidation phase. What they're talking about is when the E antibody develops, that's considered a consolidation phase. And the induction phase is when the E antigen is still there. So a lot of times that can take long time. Sometimes it never happens. So you just keep somebody on therapy indefinitely. And by the way, the other reason not to rush into, I'm going to skip this slide. It doesn't matter. One of the reasons you don't rush into treating hepatitis B, besides the fact it goes away on its own in 95% of people, is the consequences of misreading your patient can be huge. So if you have a patient who has hepatitis C and you tell them to take their medication and they don't take it, what happens? Nothing. Their hepatitis C just doesn't go away. If you have a patient with HIV and you tell them to take their medications and they don't, what happens? Nothing. The HIV just doesn't get controlled. If you have a patient with Hep B and you prescribe them entecavir or tenofovir and they take it and then they stop taking it, they can die. So I cannot say that more strongly. You can literally kill your patient by accident if they are poorly adherent or compliant with medications. They can develop a flare. So unlike hepatitis C, which sort of just after the acute phase settles into this chronic baseline, wherever it is, Hep B can do awful stuff. It can flare. And those flares can be anything from asymptomatic to symptomatic. In other words, you can have symptoms of an acute hepatitis during a flare. And, or if you're already cirrhotic or have a lot of scar tissue, it can kill you. So, and those flares can happen during all sorts of weird times. So remember, those flares are why we are scared about our Hep C, Hep B co-infected patients, those black box warnings. So what happens there is we treat our Hep C patient with Epclusa or Harvoni or Mavorite or whatever, and Hep C goes away, but then Hep B comes roaring back and you get a flare. So that's the black box warning on the direct acting antivirals. When else can a flare happen? It can happen when Hep B treatment is stopped, frowny face. So the frowny face is, you know, this is why I usually make a patient who I'm about to treat for Hep B prove to me that they'll keep appointments, that they have a stable living situation. They're going to do labs. You're going to come see me a few times with absolutely no reward. Just come see me because you want to come see me and visit me a few times, prove you're reliable, and then we'll treat you, because it can be nasty if you don't. There's a bunch of other reasons that you can flare from Hep B. None of these matter a ton, except for when we get down to some of these down below. And it's immunosuppressives and steroids and stuff like that. So this is a cool little learning point. So I have seen people who get poison ivy and get prednisone for poison ivy. And then they finish their prednisone for the poison ivy. And then 2 weeks later, they're jaundiced. What happened? And then they get diagnosed as an acute Hep B. They actually don't have acute Hep B. They did not have the world's first case of acquisition of hepatitis B from poison ivy. They, in fact, already had Hep B, but it flared. It was just unknown. So, and by the way, just as a tricky quirk of nature, your IgM core can turn positive again. So, you know, your IgM core is this thing we trust to tell us someone has an acute infection. It's lies. It doesn't always tell the truth. You can have an IgM core during a flare. So just be aware. I've seen this also with COPD patients who, you know, undergo a little steroid blast and then get what looks like an acute flare of transaminases. And then lo and behold, it turns out they had Hep B. So just remember, Hep B is that of the viral hepatitis, it's the sneakiest. It can flare and act funny in the setting of immunosuppression. You know, all the commercials on TV for the, you know, the anti-rheumatic agents, anti-psoriasis stuff, when it says, tell your doctor if you have hepatitis and blah, blah, blah. They're not worried about Hep C. We're worried about Hep B. Okay. And cancer chemotherapy, you know, the oncologists are unbelievably aware of Hep B's propensity to flare up and cause trouble. I don't have too much data on here, but I'm not going to tell you the rest of this stuff, blah, blah, blah. Yeah, I already said it, flares. Just know what this slide says is that Hep B never really goes away. Remember, it forms many chromosomes. It's a DNA virus. Almost think of it as like a herpes virus. It's just sitting in there lurking and can cause trouble, even in people who have established immune control. So if you're somebody who has core antibody positive and anti-surface antibody, in general, we don't sweat those people. We're like, all right, you're good, you're happy. And that's true. And they're safe to undergo Hep C therapy and other stuff like that. But if you were to unbelievably immunosuppress them, such as giving them an anti-CD20 therapy or giving them a stem cell transplant, even those people with really good immunologic control can wake up their Hep B enough to cause trouble. So sometimes we even offer preemptive therapy. So if you have somebody who's going to undergo one of these therapeutics, we sometimes put them on treatment ahead of time to prevent flare-ups. That's what all that stuff says. This is all about preemptive therapy. Too much data. Y'all don't need to know all that stuff, but just know the concepts that concept of putting people on preemptive therapy has a really, really complicated algorithm to figure out. We basically look at what is your serologic status and what is your degree of immunosuppression, and then come up with a plan. But remember that certain drugs, such as those anti-CD20 drugs, the Rituxan family, are the ones that are super, super prone to wake up Hep B, along with other chemo. Stem cell transplant stuff. So vaccination, you know, I went through those depressing statistics on the first time I talked about this being a top 10 cause of death worldwide. I mean, this is a nasty virus, kills a ton of people. 5% of humans have it chronically worldwide. And this is a preventable illness. So there's a vaccine that we can prevent this with, unlike Hep C. So we actually got a beautiful vaccine. Who should we give it to? You know, fortunately, most children get it nowadays. So it's built into childhood vaccination schedule. So long-term, this is wonderful news for the population at large, but we have a lot of catch up to do on these people with potential risk factors. And these risk factors are very logical. If you kind of think about the transmission risks, they're sexual, their injection drug use, their blood exposure type risk factors, and of course, protecting people with chronic liver disease and other stuff like that. You know, this international travelers is interesting. This is, remember, Hep B is not fecal oral. There's no hepatitis B shed in stool. The concept here is that people, when they travel, engage in high risk activities, including sex, drugs, etc. So, or potentially getting blood transfusions, you know, if you had a trauma internationally. So we in general think of giving people Hep A vaccinations prior to international travel, but consider, you know, vaccinating for Hep B as well. And remember our Hep B vaccine options that we have in the US. There's a couple that require 3-shot series. That's the Recombavax and Energix B. And those are our traditional recombinant Hep B vaccines. And then we have the newer approved one in 2017. That's a 2-dose series that's even more immunogenic, more expensive, but more immunogenic, the Heplisab B. And consider using the Heplisab B if you have a prior non-responder. And then if you take care of kids, there's a couple cool pediatric combination vaccines that I wasn't even aware of, honestly. I didn't know you could get your inactivated polio, DTaP, and Hep B all at once, and so on and so forth. But and then, I'm going to leave you with one happy bit of information. So for an infection that really affects 5% of all humans, and it does that primarily from mother to child transmission, we have actually a really good prevention strategies to prevent mother to child transmission. So, and this is limited to, spoiled, resource rich countries like ours. And that's one of the bummers is, yes, we can really prevent mother to child transmission, but we're a low endemic country. I wish the strategies could roll out worldwide quickly. But what we can do is you can actually give mom antivirals during her 3rd trimester of pregnancy. And again, this is usually tenofovir. This is only indicated if mom has a wickedly high viral load. So if mom's viral load's a couple hundred, you don't have to do anything for mom. And but if it's really high, you can give mom antivirals right in her 3rd trimester. And then as soon as baby comes out, you give baby preformed immunoglobulin and a vaccine. And with this strategy, it's like 99.9. It's really good at preventing mother to child transmission. So if you think about our chronic viral illnesses, Hep B has this beautiful mother to child transmission prevention strategy. HIV has a beautiful mother to child transmission prevention strategy. Really, our only chronic viral illness that we deal with routinely that doesn't have a mother to child transmission prevention strategy is Hep C. We have nothing analogous for Hep C, so kind of a bummer. But anyway, that's kind of the good news for mother to child transmission prevention in the developed world. Questions from anybody on Hep B, hepatitis B? A little bit scarier than Hep C. Harder to deal with and incurable, but we can control it. I'm going to stop my share and see if there's any questions.
Great. Thank you so much, Dr. Gilfus, again, and leaving it on a nice note. We do have a question in the chat. I believe it says no need to give Hep B vaccines when Hep C core AB is positive, but Hep B surface antibody is negative.
Right, when the Hep B core antibodies positive.
Hep B core. Okay, it's AB positive.
Yeah.
Tammy, did you want to go any further into that?
So
Or that
you can do it. You're not going to hurt anybody, but you don't have to, because most of the time what that represents is somebody who had a prior remote infection and they're just simply their surface antibody titer has declined. The only way it would really help is if it was a false positive.
Thank you so much.
That being said, if you talk to like 3 or 4 GI docs, the majority of them just go ahead and give it just because there is no harm.
Does anybody else have any questions? Or Tammy, did you want to go further into that?
Yeah, I'm glad you clarified that, because previously I was thinking that if the core antibody was positive, you definitely wanted the Hep B surface antibody to be up. And so it's just the opposite of what I was thinking. So thank you for that.
Sure. And one of the things, if you ever do want to see it high for any reason, say like the patient's going to undergo massive chemotherapy, you just want to make yourself feel better. You can give just a 1 shot and see what happens, like almost a booster, and be like, aha, I've woken up that amnestic response that is demonstrating that they actually did form surface antibody. So, yep.
Okay, thank you.
Sure.
Thank you so much. Does anybody else have any other questions? All right, well, thank you very much for a great session again. Our only announcement is the next will occur on April 14th with Gene Colonel discussing cirrhosis management. So I hope you guys have a great beginning to your April, and we look forward to seeing you again. Bye-bye.